Hey y'all, welcome back. And I want to start today by offering congratulations. You have made it to your final video lecture for psychopathology and clinical diagnosis for this term. I'm really pleased with and impressed with the learning and work that you have done to this point. And I'm certainly looking very much forward to what y'all turn in for your final signature assignment and how well you do on the sort of the multiple choice final exam. We will, in this video, cover directly the classes of disorders listed in Module 7. We also have Module 8, which I'll get to in just a second. In Module 7, we are covering the disruptive impulse control and conduct disorders, elimination disorders, sexual dysfunctions, and the T and Z codes. In this video, we will directly address disruptive impulse control and conduct disorders with a brief comment on the T and Z codes. I have prioritized these in this final video because you are very likely to work with clients and with relevant presentations of these classes, especially if you work with children and families. You are less likely to be working with clients where elimination disorders and sexual dysfunctions are the primary focus of treatment, and these may be the focus of other courses in your future, especially in regards to the sexual dysfunctions. You will be responsible for the DSM and gray text content on these disorders, even though we're not going to directly address them in this video. Module 8, as I just mentioned, is next week, and that is a catch the rest module. You will not be tested on these. And in fact, I believe this video is coming at the very end of sort of the way that we do things here at Lindsey Wilson. We will be moving more to a 7-module model starting in the fall. In Module 8, or I suppose the disorders we have not covered include the sleep-wake disorders, which are unlikely to be a focus of your work. They are more of the purview of rehabilitation counselors or sort of more medical professionals. There's also substance-related and addictive disorders. This is the focus of another course, the Substance Abuse and Addictions course. Neurocognitive disorders are also a class that we're not going to cover directly. It may be the focus of your work if you are working in a rehabilitation or geriatric clinic setting. This is often the purview of rehabilitation counseling. Also in this module, among the disorders we have not covered are the paraphilic disorders, which may be a focus if you plan to go into work that involves the treatment of sex offenders, which is associated with a separate certification. So you are likely to receive, if you choose to go that direction, you are likely to receive more specific training on those presentations and that kind of work. So let's talk about the T and Z codes first as we move into the direct content for this video. So the T and Z codes are a class or chapter that comes at the very end of the DSM-5 TR, and it has been sort of the end of the DSM-5 as well. In DSM 4 and previously, these have been considered V as in Victor, V codes. And these are sort of often used as secondary or tertiary diagnoses to provide treatment context. They are not necessarily considered disorders in and of themselves. They are the focus of clinical attention, and I'll provide some examples of what might show up in your work. So if you're working with a child in family work, you might code Z62.820, Z62.821, Z62.821 or Z62.822 for a specific type of a parent-child relational problem. I believe Z62820 is parent biological child difficulties, 821 is parent and adoptive child, and 822 is parent and foster child types of problems. Again, these are not often primary codes because third-party payers, such as insurance companies, do not recognize them as part of reimbursable treatment. However, they are very useful for you clinically, your clients clinically, and also others who may have a clinical or other interest in the work that you're doing, because they provide context that may help explain the more primary diagnosis in terms of the mental disorder that you're providing treatment for. So that's the T and Z codes. You will also find in that class codes related to abusive situations, whether it be child abuse or intimate partner violence, substance-related conditions, and things of that nature. So I do invite you to take a close look at those, and you are going to be responsible for being familiar with that class on the final exam. Okay, so what we're going to spend the most time on today is the Disruptive Impulse Control and Conduct Disorders class, because you are very likely to encounter clients with diagnostic presentations that fit this class, especially if you're working with children and families, like I mentioned before, and also working in settings such as community-based or acute care types of settings. This is not unlike the trauma and stressor-related class, in that these diagnoses are vastly overrepresented in populations affected by poverty, trauma and violence, and incarceration, kind of going back to the close association with adverse childhood experiences and this class of disorders. In this class, we're going to discuss them in a little bit out of order, just because there are some that are more related to others. You will find that in this class, oppositional defiant disorder, or ODD, is listed first. And like we've talked about before in other videos, the DSM-5-TR, just like the DSM-5, is organized developmentally, and so disorders that are likely to present earlier in the lifespan show up earlier in each class of disorders. We are going to jump over ODD just briefly to discuss intermittent explosive disorder, because for reasons that you'll see in just a minute. Intermittent explosive disorder is characterized by recurrent behavioral outbursts representing a failure to control aggressive impulses as manifested by either of the following. So verbal aggression or physical aggression toward property, animals, and other individuals occurring twice weekly on average for a period of about 3 months. The physical aggression does not result in damage or destruction of property and does not result in physical injury to animals or other individuals. And then 3 behavioral outbursts involving damage or destruction of property and or physical assault involving physical injury against animals or other individuals occurring within a 12-month period. So one or the other aggression that shows up as temper tantrums, tirades, verbal arguments or fights, or aggression toward property that is in animals and other individuals that occur with a frequency of twice per week on average for about 3 months, that don't rise to the level of serious injury or destruction, or 3 behavioral outbursts involving damage or destruction of property and or physical assault and that do lead to physical injury against animals or other individuals and other people occurring within a 12-month span. The magnitude of aggressiveness expressed during the recurrent outburst is grossly out of proportion to the provocation or the circumstances. So it's sort of just Yeah, it's inappropriate to the situation. It is not considered or part of another disorder. So I think this disorder has been somewhat criticized for its likelihood to appear or present like something else. We'll get into differential diagnosis about this one just a second. It's also important to recognize that the outbursts are not premeditated or committed to achieve some tangible objective. The recurrent aggressive outbursts cause either marked distress in the individual or impairment in occupational or interpersonal functioning, or are associated with financial or legal consequences, and this diagnosis cannot be diagnosed prior to age 6. So we mentioned that this disorder, which was first sort of classified in DSM-5, it was mentioned briefly in DSM-4-TR in sort of the disorders the chapter of disorders that need further attention, it showed up first in DSM-5. It was criticized because of its likelihood to look like or be sort of very similar to the presentations of other disorders. But some key differentiators include mood, premeditation, and distress to the individual, or in many cases, sort of the demonstration of remorse. So if these behaviors occur simultaneously with chronically irritable or depressed mood, then it's likely that a disruptive mood dysregulation disorder diagnosis is more appropriate. If the outbursts are premeditated, then maybe ODD, conduct disorder, or antisocial personality disorder are more likely to better account for the symptoms. And if it is without remorse, then conduct disorder and antisocial personality are the more likely sort of characterizations, or the symptoms of conduct disorder and antisocial personality are more likely to better account for the symptoms we described that are primarily associated with intermittent explosive disorder. So just keep that in mind. I think just because this one has been shown, or at least has been discussed among peers and among the clinical literature, to have close or to appear very similar to especially DMDD and ODD, or conduct disorder. So that is sort of a broad overview of intermittent explosive disorder. And so we're going to get in now to ODD, conduct disorder. A lot of similarities between the two. And then we'll talk a little bit about sort of the final two disorders in this class, pyromania and kleptomania. ODD is a diagnosis that is very widely sort of used, especially when working with or trying to understand behavioral presentations of young people, elementary and really school-age children. And I like to reframe it as sort of underdeveloped activists disorder, and we'll get into that and why I say that in a little bit. Before we do that, I think it's important to note that ODD is a pattern of angry or irritable mood, argumentative or defiant behavior, or vindictiveness lasting at least 6 months, as evidenced by at least 4 symptoms from any of the following categories. Okay, those categories are irritable mood, argumentative or defiant behavior, and vindictiveness. There are essentially 8 sort of symptoms, and at least 4 of them must be met. and they must be exhibited during interaction with at least one individual who is not a sibling. Okay, oftentimes it's going to be an authority figure, a parent, a teacher, a community helper, maybe a police officer, someone of that nature, someone who has sort of a power differential with the client, but is not necessarily an adult. So, in the angry, irritable mood category, these symptoms manifest as frequent loss of temper, sort of a touchy or easily annoyed sort of presentation, I want to say attitude. That's not, maybe that's kind of what it is. I'm careful about using the word attitude because in our common vernacular, we might say something like, oh, you know, they caught an attitude with me. That really doesn't have a whole lot of meaning because it's kind of overused. The meaning is diluted of attitude. The point here is that the person's mood is often touchy or easily annoyed. And the person is often angry or resentful. Those are the three symptoms in the angry, irritable mood category for ODD. In the argumentative/defiant behavior category, the symptoms are sort of frequent arguments with authority figures or for children and adolescents with adults in general. Frequent active defiance or refusal to comply with requests from authority figures or with rules in a certain environment, school, home, whatever it may be, or just in maybe a doctor's office. Sort of a frequent deliberate annoyance of others and frequent blaming of others for mistakes or misbehavior. And then finally, there is a category for vindictiveness, and this is getting at a person that has been spiteful or vindictive at least twice within the past 6 months. So, again, there are sort of three categories of symptoms. At least 4 of those symptoms must be exhibited within a 6-month sort of time period for a diagnosis of ODD. So, a couple of important notes, and then a few words about sort of the way I like to characterize ODD. Note number one is that clinical judgment must be applied to determine if behavior is symptomatic or within normally expected limits for the developmental level. And so it's really important that you have a strong grounding and familiarity with human developmental theory and kind of what is expected of people of a certain age, and that you also take into account sort of other factors. Maybe there's a developmental delay of some sort that needs to be accounted for in the event that there is another explanation that's rooted in biology or just human development, then ODD should be avoided. Also, note number 2 is look for remorse. Is there some sense of regret or feeling bad about the angry, irritable mood, defiance, especially defiance or vindictiveness? If people aren't proud of that or don't accept that in themselves, have remorse or regret, that is likely to be, ODD is likely to be a better accounting for this list of symptoms. If not, then you probably are dealing with a conduct disorder or antisocial personality type of presentation. So, a few words about underdeveloped activism, okay? So first, ODD is, I think, criticized because, at least in part, it is just a description of behavior without acknowledging the etiology or the origin or what explains the behavior, such as what you might find in the trauma and stressor-related class. So the risk here is that people in authority, parents, teachers, clinicians, that we stop there at the sort of diagnostic level, like just checking boxes. They describe a person's behavior. They diagnose a kid with ODD, which has an enormous amount of stigma associated with it. And then they stigmatize or write the kid off, right? We are going to move on with the other kids who are better behaved, more pleasant to be around, right? That would be a perhaps understandable, if still inexcusable, sort of move for a person in a teaching, parenting, or otherwise sort of caregiving and power position with a young person. To counteract that impulse, I'm introducing to you sort of Rudolf Draker's 4 mistaken goals of behavior or misbehavior, to kind of help with this, sort of reversing the trend. All right. So first, remembering Abraham Maslow and his hierarchy of needs. So Maslow in the hierarchy identified that belonging and esteem or mastery are the 3rd and 4th levels of the hierarchy. All right. So here's my marker. So all human beings, from early in their development, are seeking a sense of belonging within the group that they find themselves, okay? And so we can represent this by sort of just drawing a line. People are walking the ground toward belonging, all right? And they also are going to want to experience a sense that they can make a meaningful contribution to that group. That we'll get into that in here in a little bit too. Okay, so like I said before, it has been established in psychology that human beings at the 3rd and 4th levels of the hierarchy of needs need to feel like they belong to a group and that they can make a valuable contribution to said group. Now, young children, typically between the ages of 2 and 4, start working on getting these needs met in sort of behavioral and otherwise communicative forms, okay? And so they start working on getting these needs met, and when their first attempts are not recognized, they are likely to develop maladaptive habits, okay? So this is where Draker's 4 mistaken goals of misbehavior start to show up, okay? So, and this can begin to present as early as 3, 4, but typically around 5. Once children are starting to move into kindergarten is when they start to really be identified, because you have more adults in different settings involved in the child's life, okay? And so if early attempts fail to help a person develop a sense of belonging with their identified group, they are likely to start digging a metaphorical hole, okay? And so at this first level, okay, are behaviors that have been identified as or described as seeking undue attention. Okay. Oftentimes these types of behaviors feel very annoying to the adults or other authority figures because the child needs to be constantly reminded or X, Y, and Z for doing the thing that they're doing. Oftentimes these things are not necessarily, but they can be sort of deliberate, okay? And each of these behaviors, I should mention, okay, has a suppose a remedy, and I will use sort of a ladder diagram to sort of indicate those, okay? So first we have undue attention, and what's kind of underneath all this is a desire for the child to be noticed, okay? So the child's kind of saying, perhaps in a difficult to recognize way, notice me. You involve me in the group process, the family process, in a useful manner. All right. And that's the top rung of the ladder back to the sense of belonging. At the second level of the downward sort of energy, when these attempts to feel noticed and involved through attempts to get undue attention are, again, not recognized, this leads to behavior that is manifesting sort of misguided power or a power struggle. Okay. And then, of course, the remedy is letting the child help, and then also giving the child options. So you may have heard about that in the techniques courses you may have already taken, or that you will take, is to allow the, essentially give the child a job so that they can make a meaningful contribution. So the next rung on the ladder is let me help. Give me options. So if you get into a power struggle with your 3-year-old, say, not that I have any personal experience with this, over eating breakfast so that you can get to school on time, give the child options for what is available. So, honey, you can have oatmeal or an English muffin. Of course, these are things that the child you identified, they are interested in. They have shown interest in these things. And oftentimes that gives them a sense of their own agency, right? They can belong while also having their own voice and say in what goes on in their life, okay? So that's the second rung back toward belonging, okay? Thirdly, on the downward sort of trajectory, if the misguided power struggle is not sort of interpreted and reframed as a let me help, give me choices, and then responded to in that way, you are likely to get sort of behavior that shows up as revenge or retaliation. Are y'all hearing yet the symptoms of ODD? The sort of implicit message here on the reframe side is a message of I'm hurting. Please validate my feelings. Our third rung of the ladder back toward belonging. And then finally, if these attempts are still unmet, you are likely to get to a point where here at the bottom of the hole, a person assumes inadequacy. This is often associated with a phenomenon also called learned helplessness. They have attempted to get their basic need met for belonging and to make a meaningful contribution. And these attempts have chronically been sort of unwelcome or rejected or missed. And so the child sort of gives up and shows up as apathy. And is very difficult at this point to reach them and to sort of turn the momentum back toward a healthy sense of belonging. So the implicit message here, the reframe, is essentially, don't give up on me. Don't give up on me. Give me a small step back toward getting my third and fourth level needs met. Okay? And so if you are in a situation, let's put it this way. So that's my first point here, is that ODD is a description of behaviors that often lead to impairment in primarily academic and social functioning for children and adolescents, but they can progress into adulthood without really acknowledging what sort of the basic need is, what the etiology of the problematic behavior is. In the attachment world, we call these behaviors sort of attachment miscues. So a child may be acting in a way that is sort of clamoring for undue attention or misguided power, and that's sort of the miscue that's sort of indicating I need something from you. I need the attachment figure to be present and available. I need to be noticed, involved in a useful way. I need to be participating and helped, and to help with the process. I need some options to make that happen. And so, yes, it's important to recognize that ODD comes from somewhere, and it is our responsibility as clinicians to solve that mystery to the best of our ability. So, my second point is that it comes from my own personal and professional experience, right? When I have worked with young people exhibiting this presentation, and I worked with them frequently, especially when I was providing intensive in-home counseling in my home community at a private but community-based agency. When I was working with children and adolescents who exhibited this presentation, the presentation could be attributed to the adults in their lives having no credibility or losing credibility with the younger person, oftentimes because they didn't recognize sort of the underlying reframed cue that the child was expressing in their need, okay? So the younger person gave very little credibility to the adults in their life, and the younger person came to believe that they have little or no power in an intolerable relationship, okay? That is, they don't have a voice. And so it's important to note that a parent, guardian, teacher, or otherwise may be doing the best they can, okay? Going back to the hierarchy of needs, a lot of times, especially people living in poverty, are, as parents, are often doing it by themselves, right? So they're doing the job of two, maybe more people. They are doing it in ways that require them to work and be outside the home, be unavailable physically for their children, and then come home exhausted, so that they are unavailable emotionally for their children. So it's important to be careful to avoid judgment of the parents in these cases, as well as other providers. So like I'm thinking about teachers who are often in overcrowded classrooms and are sometimes caught up in this system because what they are longing for is for class to be run smoothly, but for whatever reason, one or more children are sort of interrupting and blocking that goal. These are children who often have come to believe that their voice does not matter, and the adults have very little, if any, credibility with them, and those adults may be stuck in this situation because of other systemic pressures upon them. Thirdly, when working with a client with ODD, be sure to do a deep analysis based on behavioral principles. Remember our ABCs ASAP. So run sort of these types of goal-driven behavior through the ABC narrative. You know, what happened right before the behavior happened, what is the actual behavior, what was the consequence of the behavior, and then if you can understand the consequence of the behavior, did it happen again? If so, it's probably meeting one of the 4 functions of behavior, right? If we can understand the function of the oppositional or defiant behavior, we can determine what is understandable about behavior and then help the client develop new, perhaps non-violent and non-vindictive behavior that meets their basic needs and promotes self-advocacy toward meaningful change in their environment and relationships. So, as one of my heroes, the late Representative John Lewis, is famous for saying, good trouble leads to empowerment, which then leads to improved mental health. All of that can be used toward turning the hole-digging momentum into climbing the ladder back toward a sense of belonging and mastery, improved mental health, improved self-efficacy, and just a general sense of empowerment in the world. So, ODD, as difficult as it can be to work with, as difficult as the children that are presenting that way can be to work with because of the ways in which they have been essentially primed to present in ways that are hard for people in power positions like us clinicians, to work with. It actually has a fairly good prognosis as compared to other disorders in this class, namely conduct disorder. Okay, so moving into conduct disorder looks very similar in many ways to ODD, but it is has a very concerning prognosis. Okay, oftentimes people who are presenting with conduct disorder in childhood and adolescence, those sort of problematic patterns of behavior and relationships persist into adulthood and begin to really kind of manifest as antisocial personality disorder. Oftentimes, people with conduct disorder are also going to be overrepresented in juvenile detention settings, okay, similar to their adult counterparts of antisocial personality disorder being overrepresented in incarcerated populations. There is likely to be limited insight, perhaps because the things we talked about with ODD have been so chronically sort of practiced for the child over time that there's sort of an internalization of these problematic patterns Oftentimes, conduct disorder, just like antisocial personality disorder, is associated with sort of getting the sense of belonging and also mastery, sort of being able to have an influence on the environment. That they kind of are reinforced by causing harm to others, because that is sort of the way in which they are influencing and affecting the environment around them. And this is so well practiced that people sort of internalize this. It becomes part of their sort of internal working model for relating to themselves and the world around them. It also may have a genetic component similar to antisocial personality disorder. So we have to be careful to avoid attributing the behavioral patterns solely to environmental factors. All right. So conduct disorder is specifically characterized by repetitive and persistent patterns of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated, as manifested by the presence of 3 or more of the following 15 criteria within the past 12 months from any of the categories of aggression toward people and or animals, destruction of property, deceitfulness or theft, and then fourthly, rule violations. Okay, so there are 4 categories of sort of symptoms, but only 3 are necessary for a diagnosis within a 12-month period. All right, and these patterns must be persistent and repetitive. Okay, so in the aggression toward people or animals category are included frequent bullying, threatening, and intimidating others, initiating physical fights, using weapons that can cause serious physical harm to others. Could include something like a firearm, but typically it's things like rocks or bricks or sticks, things of that nature. Just because those are much easier to access. Fourthly, sort of physical cruelty to humans. Similarly, physical cruelty to animals. Stealing while confronting a victim. This is kind of like mugging, or can kind of be manifested as part of bullying. And then a 7th symptom in the aggression toward people or animals category is forced sexual activity. In the destruction of property category, this includes fire setting with destructive intention. That's a really important caveat there. Fire setting with a destructive intention. And then also deliberate destruction of others' property other than fire setting, such as vandalism. In the deceitfulness or theft category, the symptoms include breaking into someone's house, building, or vehicle, lying to obtain goods or favors or to avoid obligations. So this is, as you can see, these are all very goal-driven, okay? And then stolen items of non-trivial value without confronting the victim. So these are things like kind of burglary, breaking, entering kinds of theft. And then finally, in the category of rule violations, the person has stayed out at night despite parental or caregiver prohibition. This is sort of started before the age of 13. They have run away twice from home and stayed gone overnight while in parental or surrogate care, or once if it is a lengthy period of absence. And then also the person is often truant from school beginning before the age of 13. Okay, so again, just like most, if not all of our DSM-5 disorders, there must be identifiable impairment in social, academic, or other functioning. The client likely lacks insight, so professional determination is often necessary. A person must be younger than 18 to receive a conduct disorder diagnosis. Otherwise, antisocial personality disorder best accounts for the presentation. And then there are a pretty extensive list of coding specifiers. Okay, so you must code for the age of onset. So there's a specific code for the presentation of conduct disorder prior to age 10, after age 10, or unspecified. There is also a specifier for emotional characteristics. So if a person presents with limited prosocial behavior, lack of remorse, lack of empathy, sort of a lack of concern about their performance, you can tell these things are showing up here. There's apathy, disinterest in being in sort of cooperation, and completion of these developmentally designed goals, especially in the education system. And then fifthly, there's sort of a specifier for shallow or deficient affect. So if a person is sort of blunt or flat in their emotional expression. Also remember, like, there are associations with conduct disorder with disorganized and in the organized categories or presentations of attachment, avoidant attachment patterns. And then, of course, finally, there is a series of specifiers for severity, so mild, moderate, and severe. Pay close attention to those. The presentation has deep roots where the person has typically assessed that these behaviors are so reinforcing that meaningful change is unlikely. Not impossible, but for, as I mentioned before, these conduct disorders often vastly overrepresented in juvenile detention populations, and the provision of treatment is likely to require very restrictive interventions, right? Very concrete behavioral interventions to, in some ways at least, give small steps and to not give up on this person, to turn the momentum back toward a sense of belonging and a interest in participating in social systems, whether it be at the macro level or the micro level of Bronfenbrenner's sort of ecological model, whether it be family, school, or other sort of governmental, societal types of rules and norms. So that is sort of a broad overview of conduct disorder. And look forward to questions, comments you might have. Please place those in the discussion board for this module. The class of impulse control and disruptive behavior conduct disorder sort of diagnoses concludes with two diagnoses that are sort of subsets in some way, that at least resemble subsets of conduct disorder, okay? This is pyromania and kleptomania, okay? Now, it's important to note that in some ways these have sort of compulsive qualities to them, right? So pyromania is, as you're probably aware, sort of fire starting, okay, behavior. But this fire starting is not directed toward destruction of property. The primary goal is sort of satisfying a fascination with fire setting for fire's sake, okay? Similarly, kleptomania is related to stealing behavior. Also typically has compulsive qualities and is not directed at power or intimidation, but instead a fascination with the thrill or other aspects of stealing. So these don't show up in the compulsive category because they are more associated with impulse control, which is sort of, these are not necessarily compulsions, but more impulses that are related to fascination with these behaviors, fire setting and stealing, and that's kind of the way that the DSM-5-TR classifies them. So it is possible to have pyromania and kleptomania without a diagnosis of conduct disorder, or even ODD, again, one of the key differentiators is remorse. You are more likely going to see remorse in pyromania and kleptomania than certainly conduct disorder, maybe even in ODD. Those have a better prognosis for sort of being, for people recovering, having new habits formed and shaped that enable them to control the impulse of setting fires or taking other people's property, taking things that don't belong to them. So that is our broad overview of this class. I have placed a sort of a case example underneath this video. And I'm very curious about your impressions. I'd be curious and interested in responding to your comments or questions about the case example. I'm curious about what, kind of what your initial diagnostic impressions are. So please take some time to participate in the discussion board, and I look forward to meeting you there, and happy to take on any other questions or comments you might have as we head into the final sort of week and a half of the term, and you prepare for your signature assignment, sort of the final case vignette report, which functions kind of as your written portion of your final exam, and then also the multiple choice portion of your final exam. We'll, I'm sure, talk as a group and on the individual level very soon. Thank you.